So let's turn now to our keynote. I would do drum rolls, please, if we were in person. And we all know has been a forerunner of the importance of incorporating an approach to underserved groups and underrepresented groups in research, and also the power of data science to uncover missing stories and also to try and suggest solutions, not just leaving it at counting and characterizing. So I'm in great anticipation, Anne, no pressure. And I will hand over to Andrew, who I think is going to introduce you slightly further.
Oh, hi, Sarah.
Sorry,
no, I think you've covered it. I was just going to say that Anne will be very well known to everybody as a Professor of Health Data Science at Swansea. She wears many hats, one of them being now the co-director of the new mental health HDR UK Informatics Hub, DataMind. But I'm not going to say anything more. Anne, over to you.
Thanks both. I'm gonna it's interesting to do a keynote at the end of the day, and I'm sure many of you are very tired, but this is a really important topic, and I'm going to focus it on ethnicity data, but then I'm going to proviso that with the idea that I am not an expert in sort of mental health issues related to ethnicity. You know, the focus of my research is on children and young people's mental health and suicide and self-harm prevention. However, from the beginning, so since when I was working clinically as a GP through my public health training, I've always had a focus on inequalities. And most health inequalities that we see exist in underserved and underrepresented groups. So for me, throughout both my clinical and my research life, this has been a huge focus for me. And I think, you know, when we think about COVID, I was involved, you know, we were all searching for answers. We've heard quite a few studies today looking at the impact of the pandemic on mental health. And I guess linking back to the previous session, you know, if we look, lots of the data that we have is often, you know, quite out of date. But this study that I was involved with, it shows that you know, mean GHQ has not returned to pre-pandemic levels. Now, it's not hugely different, but if you think of what we call in public health as the Rose paradox, when you have a small change at a huge population level, that's a big impact. But we also did a piece of work where we looked at the trajectories of people's mental health during COVID. And basically, if you look at the bottom 3 lines of that bottom graph, you know, this was presented by Catherine Abel, I think, at the science meeting last year.
Anne, can I interrupt you a second? So I don't see a graph. I might be the only one, but I don't see any slides. But again, it might just be me.
No, I can't see any slides.
Let me try again. There we go.
Bingo.
You see those?
Yes, they're not in presenter mode, but yes, we can see them.
Presenter mode?
Yeah, perfect. Thanks.
Wonderful. So that's slightly embarrassing because I've been talking like you can't really see me, but that's fine. So if you look at the bottom graph, what you see is that for the vast majority of people, we saw that change in their mental health just after the pandemic happened. I'll get to why this is relevant in a minute. And then for 2 groups of people, so that's the red line and the dark green line, their mental health, as measured by GHQ-12, was either consistently poor throughout the pandemic or deteriorated. And when we looked at who was in that group, it was people from deprived communities, it was people from ethnic minorities, it was young people, it was people with pre-existing mental and physical health. And my first reaction was it's the same people. So in almost all the studies that I've been involved in during the pandemic, it is the same group of people who are experiencing problems. Now, those differences in health outcomes for underserved and underrepresented groups are not unique to COVID-19. They have been around for decades. And what has changed because of the pandemic is that eyes are focused on it now. And one of the other things that has changed during the pandemic is, I don't know what it was like for all of you, but if I ever said to anyone, oh, I'm an epidemiologist, people's eyes glazed over. They didn't know what that was. Mental health, people are interested in, but epidemiologists, no, that's all changed. However, I think expectations have been raised to a level that policymakers and people are almost expecting real-time data to inform the decisions that they're making. And if you think about all the conversations that we've talked about, that means there's an even bigger onus on us to get the data right. Because if today's shown anything, is you've got to think about the tools that we're inputting into our studies. We're working with larger and larger data sets. So the ability to, get significant findings is always there. So it's really important, it's a very fundamental public health sort of mantra. We need to get our case definitions right. We need to know that our data quality is right. But this focus on inequalities really provides an opportunity for us to address long-standing inequalities in health. And what's really changed, I think, is the conversation. So the conversation isn't just about, oh, well, they've got worse lifestyle factors. It has exposed structural and social inequalities as vulnerabilities for poor mental and physical health. All the things that Marmot said in his 10 years on review, where he also highlighted people from ethnic minorities. However, where with that comes the responsibility to do the science robustly, with the understanding that this sort of data, this sort of real life, administrative and routinely collected data, it really speaks to policymakers. So I've sort of sat in that space between doing research and advising government for probably about well over a decade now. And during COVID, I was sort of sat on SPI-B, co-chaired SPI-B, I sit on SAGE. So we did lots of government advice on evidence and research during the response to the pandemic. And, we saw with all the modelling, with people talking about R numbers, that counting counts. So it really, the opportunities are amazing. However, for ethnic minorities in mental health, we know that experience and outcomes of severe mental illness in people from ethnic minorities are worse. There's a higher incidence of psychosis. There's more coercive care pathways, by which I mean there's more contact and involvement of the police and the criminal justice system. There's more mental health act use. There's less primary care involvement. In my field, we know that people from ethnic minorities who present to emergency departments are less likely to receive a psychosocial assessment and to re-present with self-harm. And often it's that experience of that first presentation with self-harm to the emergency department that can really affect the way people present in the future. Now, we all knew that, but you didn't see the conversations happening about the data and how we were counting and what we knew about this. So there was lots of discussions about, you know, if you look at ethnic minorities, were you thinking about the intersections with deprivation and access to services in terms of these outcomes? So there was some sort of quite academic discussions about data to do with ethnic minorities, but the focus that is there now didn't exist previously. And some of that is about how ethnic minority data is categorized. So there's a long history of, one, mistrust in relation to science and medical science. So the Tuskegee syphilis study is a very famous example, and you know, it still shocks me that that study ran till 1972. We're not talking about these things occurring, you know, way back when. And then Windrush, which was all about not having official data and appropriate data. That's very recent. And what that's resulted in is there are definite trust issues in terms of data and officials amongst certain ethnic minority groups. And what that means is there's a bit of a tension between that idea of BAME, which is very out of favour now, so grouping everyone together so it's a stronger message, and the idea in research where we really want to segment the different categories so we have a much deeper understanding. But mixed up in that is people's mistrust of recording and how the state will use it. And also the idea, so I know for me, I grew up in North London, and really up until I think I started my public health training and got a real understanding of what data was about and its uses, I always prefer not to say. And I think there's a lot of work we need to do with people about understanding the benefit of data. So we've only recorded ethnicity data quite, not for that long. So in primary care, only since 91, in hospital statistics since 95. Recording was very incomplete. They incentivized it in QOF, and that did dramatically improve completeness. Who knows about accuracy? And there was this one study that looked at the agreement between ethnicity coding in CPRD and HES of ethnic minority groups. And for people of South Asian ethnicity, and I guess what I'd say about that is that I would be categorized as South Asian ethnicity, but I would say my risks are very different to my parents who are a very different generation. So the complexity of ethnicity we don't always capture. The agreement was only 50%. So this data is really poorly coded, and it was weaker still for other ethnic groups, but for the white group it was quite strong. So why is that important? Well, because we know that data quality is important in understanding and addressing systematic biases in our findings. So incomplete coding, inconsistent use of coding, of which there is lots of evidence for ethnicity, means that our findings are generally underestimates. You know, there's an excessive and growing proportion of patients where it's recorded as not known, not stated, or other. And what that does is it means it impedes our reliable analysis of ethnic differences. Now, that's different across different populations in a very understandable way. So for some reason it's worse in London in adults of working age, and for patients with short hospital stays. But what that means is when we're looking at studies, particularly in routinely collected data at ethnicity, we need to do it with a healthy critique. So what that over-representation of other codes, you know, there's a real thing about othering people from ethnic minorities. So I think it's quite ironic that basically this led to a disproportionately high rate of COVID-19 and infections being recorded for other groups rather than for specific ethnic minority categories. So one thing that COVID did, because we saw those higher levels of mortality in ethnic minority groups during COVID, you know, some of which was to do with, you know, deprivation, housing, pollution, the jobs that they had, that threw into light the fact that the coding was so poor. But I guess what I would argue is we knew that already. We've seen it in other contexts, particularly in mental health. So in use of mental health services, there's been debate in journals about detentions under the Mental Health Act for a long time. And, you know, what I've listed there are, you know, 2 big reports and also work from PHE and ONS that highlight that this wasn't new. The race disparity audit in 2017 basically highlighted that the quality of data on ethnicity varies. We've shown that, but it's generally better when people report it themselves. So if you look at things like the big longitudinal studies that people were talking about earlier and surveys where people self-report their ethnicity status, completion is better, accuracy is better. In administrative data, the use of other categories is thought to be because people aren't asking the individual themselves to record their ethnicity. And there's lots of challenges to asking someone to complete a form in a clinical setting about ethnicity, which may be something that people are uncomfortable asking about. And staff may be unaware that you allow people to define themselves. We all know, you know, about the studies where, you know, new mothers were identified for BCG vaccination of their babies by their funny names. You know, it's very notable that when I had my first child, I wasn't offered the vaccination because I have a very English sounding name, and that's how the screening was happening. So there's a requirement that staff in clinical settings ask people to code themselves, but staff under pressure, people who are unwell or lack capacity, it's not an easy thing to do. When I took my daughter for and this goes back to all the things we were talking about understanding the processes of where the data comes from. So when I took my daughter for an ENT appointment, there was a scrappy bit of paper with the codes stuck just in front of the appointment computer, where they did ask me, where would you put her? She found it slightly confusing. And part of the reason it's difficult is because that ethnicity is a complex, multidimensional concept. So, you know, we think about the census categories, but often it's defined by a shared history, traditions, geographical origin, language, and literature. And we sometimes miss things like the generational aspects when we're thinking about the coding of that. It's very subjective. And so it's really difficult when an individual is required to articulate that within a simple data item. And if you talk to non-white people filling in the census, you really did stop at that category section. in the latest census. As such, when the King's Fund looked at it, they said the only true meaningful categorisation of ethnicity is self-definition. That is problematic for us data scientists, I think, because although we like to deal with clear categories, and I'm not sure ethnic minority status is that clear. So why is data quality important? And it is important because what gets measured matters and it gets managed. So limited data, it reduces our understanding of inequalities and why they happen, to identify them, how we evaluate our interventions. It also introduces bias. So, you know, there's underestimations for specific ethnic minority groups because of the other codes being used, and there's misclassification of ethnicity. So there's an underestimation of ethnic variation. We need good quality data for all the stuff that we do, for research, for needs assessments, for service planning, to monitor equity of access and outcomes, and to improve the evidence on inequalities. So you know, part of what we do should be about highlighting the inaccuracies in our case definitions and the data that we use. So there's been some huge improvements because of COVID. So basically the NHS sent out a letter. There's always been a requirement to address inequalities in the NHS. It's been in strategic plans and operational guidance, but a very specific letter went out in July 2020, requiring the NHS and GPs to comprehensively record ethnicities. Now that is important. What the everyone counts it's one of the values of the NHS. So to make sure nobody is excluded. And that means making sure they have a voice in the data. Now, lots of people who struggle to access services or won't fill in a survey because it either the request won't get to them or it might be too much. Lots of excluded populations, you know, routinely collected data, which goes beyond health data, is ONS census data, mortality data. It's where we give people a voice. Now, in England and Wales, ethnicity hasn't been recorded on death certificates, and it was a big recommendation of when the government reviewed this, and I think it will help. But and because we haven't had it, we've always linked mortality analyses when you're looking at ethnicity to HES recording, which isn't brilliant. Ethnicity has been recorded in Scotland since 2012, which is fascinating, I think. However, the quality is not deemed suitable for calculating mortality data. So I think what's going to be really important is that when we initiate that, we go to Scotland and we understand why there are issues around quality. I do think it will help, but what I would say is if you ever look at mortality data and occupational status, which is what a lot of ONS data, ONS mortality stuff is based on, you know, they ask, what's your occupation? And for lots of people put retired. So I think it's very difficult. We really do need to do a lot of training. So recommendations, there was a report that came out of the Nuffield Trust recently. So there's the issues on understanding reporting. We need to improve the underlying quality of data. So it's almost, so ethnicity can be a taboo subject. It's, you know, it's very much about getting over asking people to self-report. NHS Digital does publish data on the quality of ethnicity coding within its Data Quality Maturity Index, and there's a strong recommendation that we look at that other group. I think that we should be, any analysis of healthcare activity should routinely include ethnicity in the same way that we routinely look at age and sex. You know, if you didn't see rates adjusted for age and sex, you'd be thinking, and report on the quality of coding. Now, we recently had a paper accepted in Lancet Psychiatry, and Lancet Psychiatry now expect any results that are presented that you talk about age, sex, and ethnicity. And I think that's a really good step forward for making us push for that improvement. I haven't got many more slides. Public Health England have developed a methodology. Always remember that ethnic group classifications obscure variations by generation, by migration, by asylum seekers and refugees, and by changes in ethnicity, that generational stuff. Just from the work that I've done, overarching rates, you know, may reassure us. We saw a drop in suicide rates in the early months of the pandemic. That, you know, that may change, but there were rises in ethnic groups in the States. So we really have to think about it. Actions, APMS ethnic booster, improve coding through the HDI UK. There's a working group. Think about intersections, ethnicity, deprivation, sex, all those intersections. Think about refugees and asylum seekers. There are complex identities that aren't always captured. There's a rapid changing demographic of young people, particularly mixed race. There was an ONS bulletin recently where the risks for suicide were highest in mixed race young people. Generational effects overlooked. In the Gypsy Traveller project, one of the people we were working with used this phrase, bureaucratic ethnic cleansing, where it was really powerful, where these groups get overlooked and excluded in our data so that their needs are not highlighted. And the example she used was that if someone from a Gypsy Traveller community is housed in a brick house, their classification changes. And so that goes back to allowing people to self-define their ethnicity, because I'd lay money they'd still call themselves Gypsy Travellers. And then I guess data mined. The objectives are there. I can see Andrew wants to hurry me along. One of, it's really about making data visible. We've got 6 road builders, and one of those road builders is about making excluded and underserved populations discoverable. Myself and Dermot are going to be leading on that. And, you know, I just think this is such a vital area going forward. We've known for years where these health inequalities exist. And, you know, potentially we're beginning to get the traction to do something about it.
Thank you very much, Anne. That was superb, and I don't want to hurry you along. I wish we had a lot longer to talk about this with you, and to let you have considerably more time than you do, I'm afraid. We're going to open it up for questions now. We've got a few questions coming in. So we had one from Rudolph and one from Dermot. I'm going to ask them to patch in, to unmute their microphones and to turn on their cameras. And while they're doing that, I wanted to ask you a quick question, which was, so this is a discussion we're having at the Psychiatric Genomics Consortium at the moment. So this is a consortium of genetic studies, international studies, And there's been a lot of discussion about how we as a consortium can best record ethnicity information and use our influence to encourage others to record it in their studies. And I would guess that discussion is going on internationally. Lots of people are really engaging with this conversation now. So many of the recommendations you're making are to do with the recording of data, but I wonder if you had any thoughts on how we as consortia can influence others to record this information in a way that's helpful.
Well, I guess part of it comes back to that harmonization issue that we always talk about. So it's having some agreement about which categorization is going to be used. Then it's highlighting how that data is collected so that there isn't this overuse of the other category, which is what happens at the moment. And then I think the way that we all move forward is sort of those sorts of initiatives with journals and funders. It's almost, you make it a little bit compulsory to report on it, will eventually make it become a natural thing.
Thank you, Anne. That's a great response. So Rudolph, and then Rudolph, if you would hand over to Dermot, and I will keep an eye on the Q&A.
Thanks. We may have asked quite similar questions, but I guess you made the point, Anne, in your fantastic talk there, that self-definition of ethnicity might be the best way to go. So I was wondering how that relates to the coding of death certificate ethnicity, because if you didn't tell someone when you were alive, what are you going to do after you're dead? Is it about linking the pre-morbid, pre-mortal data to the death certificate, or are you going to be able to collect any valid new data once someone's dead if it didn't tell you before?
Well, I guess it's steps, isn't it? So I think the recording on death certificates was a very clear response to COVID because we didn't have ethnicity. But I think similarly to the way occupation is recorded, I think it will probably be quite poor. But eventually, so I think it's a way for us to have good answers for the mortality data, which was a very specific issue. But over time, I think we need it to be recorded by people throughout our routinely collected data sets.
And just a plea that it's not always by clinicians as well. But Dermot,
no, I know, absolutely.
Thanks. So I think Rudolph asked the question I was going to ask, but I'll join onto it as well. And I think just like with occupational data, I would make a case that it's really on a death certificate. I mean, it may have been included way back for legal reasons rather than public health reasons. I think it's probably better captured ante-mortem. And indeed, actually, if you look at the longitudinal studies, which is why they were set up in the first place to answer the social class, occupational class mortality, you can do exactly the same with ethnicity, assuming it's collected in the census. One of the thought occurred to me is that I obviously not my area, but I mean, is ethnicity something that perceptions change within individuals over time, in which case you may need to offer people the opportunity to reclassify themselves over time? Because there may be a tendency for, once you've put it down, you've ticked the box, you've put yourself in as a category, that's it for the rest of your life. Should people be offered the opportunity to reclassify themselves?
So I guess this is the challenge for us and the research we do, isn't it? Because it's in some ways it's similar to what's happening with gender in young people. Thinking about biology is not, and the risk factors that we're talking about for many of the things that we're interested in is not completely accurate anymore. So I do think that the categories that we have probably will change over time. So even when I think about myself, I was definitely a prefer not to say person. And the category I tick, I'm not completely comfortable with, because I know that the category I'm in is the same as my parents, and I see myself as very different to my parents. And so I think we're not very sophisticated yet at the moment. And so it probably will change, because I don't think we've quite caught up with all the different ways we need to think about it. So, you know, we've got that tension at the moment between making it so complicated that people don't fill it in. They never get past the, you know, 500 categories for ethnicity into the rest of the questionnaire, with being something that has meaning.
Thank you very much, Anne, for a very clear response to the questions, and thank you very much for your keynote. That's been extremely interesting, and I'm sure there'll be more questions to come. I'm so sorry we have to bring things to a close now. At the end, I'm going to leave the final word to Sarah, but I just wanted to say a thank you to everybody who's attended today, particularly the speakers. So thank you first to the speakers and to all the people who've chaired each session. Thank you to the organisers and to the facilitators at MQ, looking at you, Sarah, particularly. And then thank you to all of you for coming today and for attending and contributing to each of the talks, particularly if you ask questions or you raise points with others. That's been a really valuable addition to the meeting. So I think that there's been a slide indicating that we have set the dates for the next 2 MQ data science meetings. So I'm hoping that might be something that you're able to mention now, Sarah, as I sign off and just say thank you to everybody who's taken part in today's meeting. Cheerio for now.
Thank you, Andrew. Yes, and I'd love to add my thanks to that, to yours as well. And Beth, are you going to pop the slide up with the dates? Yeah, it really was a fascinating meeting. Thank you. We do have dates for next year. I'd encourage you to lock them down in your diary now. There are 3 things in particular that we're looking for. One is we will continue to have a theme of each conference. So if there are particular topics you'd like to see covered, please do let us know. We have a real interest in seeing emerging methods have good coverage and so that the community's got a chance to engage with those ideas. So please let us know about those. And of course you can submit abstracts as and when they open, but likewise you can contact either me or Beth Lindley at MQ directly, and we can keep your thoughts in mind. Also, would really like to acknowledge MRC. I think Karen Breakspear has been part of the meeting, and the MRC's investment in the Pathfinders, and then also through DataMind and the new HDR UK hub, really is instrumental to how this whole system and the whole context develops. So great to acknowledge that. And all that's left for me to do is to say thank you all. And I hope you now get the chance to enjoy some of the glorious sunshine that we seem to now have here. So we'll leave that slide up as you all sign off. Thank you very much.